Okay, thanks, John. We got a bigger venue. We voted with our feet to demand it. We heard rumors that we had such a small room because they're afraid that if it was a bigger room, the other courses wouldn't be as filled up, but that could be a rumor. So thyroid is a very emotional topic in medicine. Why more than others, I don't know, but can lead to screaming matches in the doctor's cafeteria. And we'll go through modern concepts of thyroid optimization. So again, like so many paradigm shifts, we have to leave behind some of our old ideas. First, lab tests are not that sensitive. And certainly the TSH is not the most sensitive test. Again, it's the pituitary signal of the thyroid production. It's not the actual thyroid hormone. The analogy, like I mentioned in the intro, is looking at LH to measure testosterone. If that's all you had, I guess you could use it, but it's not testosterone. And what's a normal TSH anyway? It seems to be getting lower every year. We're not evolving that fast. It's just the concept is changing. When I was in medical school, 10 was talked about as a normal TSH, then 5, then a lot of labs now say 4.5. Most endocrine journals are saying 2.5. And probably the real optimal TSH is lower, 1.5. So the best clue in terms of lab is the free T3. But in thyroidology, clinical correlation is required. And back to the basics, when all else fails, look at the patient and ask her, are you hypothyroid? Do you think it's working? And she'll tell you. And then the concept of euthyroid is not optimal. Once again, traditional medicine just deals in extremes. Hyperthyroid, hypothyroid, and the vast middle ground, euthyroid. Oh, everyone's fine. But everyone isn't fine. That's why they're showing up at your office, and you want your patients to be optimal. So just being somewhere in the euthyroid range doesn't make it. The exciting action in hormone optimization field is this vast middle range. Can't lose fat without T3. You need T3 to hit the nuclear receptors to burn fat. T3 protects against arrhythmias. Well, wait a minute. We're indoctrinated that hyperthyroidism is a cause of atrial fib. True. But you'll see how T3 protects. And with stress or dieting and a lot of drugs, T3 decreases. We'll learn the mechanism of that. And the important point is that the active hormone is T3. T4 is a prohormone. And T4 doesn't necessarily convert to adequate T3. And then to make things a little more confusing, there's reverse T3, the stereoisomer, which reverses the activity of T3 by blocking receptor sites. Medical literature shows us with so many examples how a combination of replacing T3 and T4 produces a better quality of life than just T4. Numbers may even be the same, but when you ask patients, they feel better. And there's multiple factors that affect the conversion. Dieting is classic. Dieting, the organism, human, says, oh, it's a starvation situation, time for hibernation. How do you hibernate? You stop the conversion of T4 to T3 and make a lot of reverse T3. Zinc deficiency, selenium deficiency can impair conversion. The enzymes are selenodehydrogenases. And so many drugs such as amiodarone, beta blockers, and dilantin and others will impair conversion. So hypothyroidism is getting more common. Again, is it recognition? Is it environmental toxicity? Estimated in the 10% range by Dr. Starr in the 20s, and then Broda Barnes, who developed the temperature test, which helps, but isn't really useful in every patient, in my experience. Well, first he thought it was 20% and then 30%. Jacques Hertog, Thierry Hertog's father, grandfather, see here? He comes from many generations of endocrinology. What is it? His father, I'm told his father. He estimated 80% incidence in the 90s. Well, everybody's not hypothyroid, but I'll tell you, on some days, it looks like everyone is. Why? Well, hypothyroid children perhaps didn't used to survive. Better sanitation or antibiotics, but now hypothyroid children do, and then perhaps they grow up and they meet a hypothyroid mate, and they may be attracted to each other by their hypothyroid lifestyle, and they might even reproduce. And so we get more hypothyroidism. And then there's got to be a very major environmental component. Heavy metals, other toxins, vaccines. There's more autoimmune thyroiditis. And also in the past it was underdiagnosed. So we can have failure of pituitary control. That's secondary hypothyroidism. Low TSH. Well, certainly if you look, it's not that common, but if you looked at the TSH, that wouldn't tell you what's going on, certainly. You can have failure of hypothalamic control with low TRH going further upstream. Tertiary, also uncommon. Thyroid failure, or primary, is the most common form. Then there's failure of conversion. Then there's a type 2 diabetes-like situation. Some people call it type 2 hypothyroidism, where there is resistance at the receptor level. So the hormone's there, there's just resistance. Then there's the thyroid-adrenal connection.